Well, it's my greatest pleasure to introduce to you Richard Riker, who most of you have read his publications or heard his name many, many times before. Richard is the professor of medicine at the Maine Medical Center in Maine, Portland, Maine, in the United States, and he was on one of the task force chairs of the recent SCCM 2012 International Guidelines on pain, agitation, and delirium. Richard is going to talk to us today about the insight of the new guidelines. Richard, without further ado, please.
Well, thank you, Yahya. I'd like to thank the Intensive Care Foundation and Hospira and the organizers of this presentation. It's hard to follow Gita's data. It's very exciting stuff. What I'm going to do today is to present to you the newest update of the Society of Critical Care Medicine's sedation guidelines. As you know, the first of those was published in 1995 with 13 references. The second was in 2002, which I was fortunate enough to be part of. And this one is in the editorial process right now in the journal Critical Care Medicine. And so this may not be the final version of these guidelines. It's conceivable they will shift a bit in the editorial process. But they have been endorsed by the American College of Critical Care Medicine and the American College of Hospital Pharmacists. So hopefully, this is pretty much what you're going to see. These are the people that took part in the guidelines. You can see it's quite a large group, and many of the papers that the evidence was based upon were written by many of these researchers. Just as far as by way of disclaimer, I've received some speaking honoraria from Orion and from Hospira, consulted with Hospira once in a Health Canada visit, and have received research support from a couple of universities. These are my real disclaimers who keep me quite busy. If we review quickly the 2002 guidelines, and these aren't all of them, but these are kind of a snapshot of what that existing standard was. Fentanyl was preferred for rapid onset analgesia, fentanyl or hydromorphone for hemodynamically unstable or patients with kidney injury, morphine or hydromorphone if we were using intermittent therapy, validated sedation scales with SAS, MAS, or VIX, and in parentheses is the strength of the recommendation, where A is really good and C is pretty much a flip of the coin. Objective measures like BIS not yet proven useful, midazolam or diazepam for rapid sedation. Propofol was preferred in situations where rapid awakening was needed. Midazolam for short-term use only, recognizing that although it's a short-term drug and single-dose administration, with continuous infusion it tends to accumulate its effect. Lorazepam was the recommended dose for sedation of most patients. Protocol with systematic tapering or daily interruption. So apparently these 2002 guidelines were ahead of their time. Triglyceride concentrations monitored during propofol use, routinely assessing delirium, and the CAM ICU had just been published, so was not yet well proven, and haloperidol was recommended as the drug to treat delirium. So that's what the evidence looked like 10 years ago. And we've now had some improvements with a lot of studies, some of great quality, some of not so great quality. And you can see Zog over here figuring out that sticks work better than hands to hold meat over the fire. So what was the process that the guidelines went through? We used the GRADE methodology, and this is the website if you're not familiar with GRADE. It was a transparent process to develop the statements and the recommendations. Statements may be observations opinions, like delirium is bad, but recommendations might be we suggest or we recommend that you do A, B, or C. The strength of these recommendations were based on both the strength of the evidence as published, as well as the relative risks or benefits, and we did not substitute expert opinion if there wasn't evidence. We had a professional librarian who identified the references for us. More than 18,000 references were part of that database, and each of the task force members voted regarding their opinion of the statements and the recommendations. The final term was for PAD, pain, agitation, and delirium. And the reason we moved to that term is that these are three things that we all agree are not desirable, things that we would try to treat or potentially try to prevent. And there was a believe it or not, kind of like arguing about the shape of a table at a high diplomat level meeting. Coming up with the terms we were going to call this guideline took a while. We recommended different assessment tools based on psychometric assessments, a little bit greater emphasis on the pathophysiology, risks, and management of delirium, since we now have more data looking at ICU delirium. There were 53 final statements and recommendations, about twice as many as in 2002, in comparison to the 2008 sepsis guidelines, in which there were only 36 statements or recommendations. And I think the bottom line, we are not claiming that this is comprehensive or the end-all to be-all. There were many things that we didn't have good evidence for, many questions that we asked that we could not answer, and hopefully we can identify with this document some areas for further research. So when we look at the pain, the treatment of agitation, and the delirium, this kind of cogwheel thing really identifies that it's somewhat complex. They interact with each other. And when you start to throw in measurement of outcomes, that can sometimes stop the wheels from turning in a good way or a bad way. So it's quite complex. This also represents the structure of the group. There were 4 separate groups that asked questions and then used grade methodology to answer them. The questions were PIRO, population, intervention, outcome, and the 4 groups may have asked similar questions. And when we go through the recommendations, you'll see that it appears in some situations that maybe they conflict a little bit, and I'll try to highlight those when it happens and explain why they may be a little bit different. The interdisciplinary team that we hope will implement these really swings around the corner here, from physicians and nurses, respiratory therapists, pharmacists, physical therapists, hospital administrators who may have to spend the money, and then all the way on the right-hand side, families and patients. So let's go through them. Pain should be routinely monitored. That's kind of a aha kind of thing, but nonetheless is part of the recommendation. For patients who are not able to utilize what we consider the gold standard pain measure, and that's a patient-reported numeric rating scale from 0 to 10. If you can have your patient lightly sedated, they can answer the question and point to a point on a line. If the patient is not able to communicate, either the behavioral pain scale or what we call the CPOT are the most valid and reliable behavioral pain assessment tools, but not the gold standard by any means. We do not suggest that vital signs or observational pain scales that include vital signs be used alone for pain assessment. There's just too much variability there and too many other reasons why patients may be hypertensive or tachycardic. However, if your patient does appear to have autonomic overdrive, we would recommend that you use one of the other scales or have them answer the question, are you having pain? IV opioids are the first-line drug, and we consider them to be essentially interchangeable as far as their efficacy for treating pain. For neuropathic types of pain, drugs like gabapentin or carbamazepine may be additional adjunct therapies that may be beneficial. And we suggest, note that's not recommend, a little bit less strong suggestion. We suggest non-opioid analgesics like acetaminophen, non-steroidals, or ketamine, which may reduce the dose or the need for IV opioids. As far as sedation goes, we recommend use of an analgesia-first approach. And much as Dr. Mehta presented in her sleep study, notice the first thing was pain. And then if after treating pain, there are still needs for additional sedation, it would be added in second. And we strongly recommend that approach. When you look at the entirety of our ICU patients, perhaps not all patients would benefit from an analgesia-first approach. Those who are having drug or substance withdrawal, perhaps the first intervention should be dealing with that withdrawal. Drug-induced agitation in the list here of serotonin syndromes or neuroleptic malignant syndrome, delirium, or confusion. So these drug-induced things, perhaps the first treatment would be to stop the drug that's causing the problems. And then any other agitation that may be associated with a clear and reversible etiology, perhaps treating that would be most beneficial. But generally across the board for most patients in the ICU, an analgesia-first approach to sedation. Looking for the primary causes of pain, utilizing non-pharmacologic treatments when possible, making adjustments in the ventilator, repositioning the patient, doing those types of things. And if the patient's behaviors are troublesome or pose a risk, that would be the time to intervene. So in order to do that, you need to routinely assess pain. If patients have intact motor function, but they're unable to self-report for whatever reason, then utilizing either the BPS or the CPOT, preemptively treating procedural pain, and then opioids as the preferred drug, as we already said. Consistent with Dr. Mehta's sleep study as well, maintaining a light level of sedation is associated with improved clinical outcomes. We recommend that sedative medications be titrated to maintain a light rather than a deep level of sedation unless clinically contraindicated. There's very little evidence to guide us and tell us who that is, who is contraindicated for light sedation. We don't really have that answer. We recommend either daily sedation interruption or a light target level of sedation, and I think in light of our recent presentation, perhaps there isn't the need for the DSI if you're using a light level targeted. RASS and SAS are the recommended tools to use to monitor sedation. We do not recommend objective measures of brain function such as the BIS or the narcotrend or the PSI or the SedLine or any of the other processed EEG devices in non-comatose and non-paralyzed patients. So if you're able to assess them with either the RASS or the SAS, that's good enough. If you have a patient that's very deeply sedated and is comatose as a result of that, or especially in patients who are receiving neuromuscular blockade, then we recommend that perhaps these devices may be beneficial in those patients. Just to go through the two sedation scales, this is the SAS scale, and you can see that a SAS of 3 or 4 we would consider awake, a SAS of 1 or 2 not awake, and there's a clear differentiation with the SAS scale between those two situations. The RASS scale works very well. The one potential issue of contention is a RASS of -3. So remember that definition is that you will open your eyes but not make eye contact, and whether that patient's truly awake or not, I think, is up for grabs. In some studies we've done, about 1/3 of the patients are not awake. -2 or higher, clearly awake. -3, some of those patients won't be truly awake. We recommend that sleep be promoted in patients, although again, the data suggesting true benefit from sleep, although it makes a ton of sense and we all think it's going to be good for patients, there isn't a lot of data yet to show that that's true. This is one of the big changes from the 2002 guidelines. We suggest sedation using non-benzodiazepine sedatives, i.e. propofol or dexmedetomidine, over benzodiazepines to improve clinical outcomes in mechanically ventilated ICU patients. Delirium is associated with increased mortality, prolonged ICU and hospital length of stay, and the development of post-ICU cognitive impairment. It's a bad thing. We should routinely monitor for delirium with either the CAM-ICU or the ICDSC, the one that Dr. Mehta just told us about. Both of these are well validated and shown to be reliable in ICU patients. Coma, and we're talking now about drug-induced coma, not intracerebral hemorrhage or traumatic brain injury, is an independent risk factor for delirium. Benzodiazepines may be a risk factor, and there's not enough data right now to identify the relationship between propofol and delirium. This is the ICDSC, the scale that was used in the sleep study. You can see that it's an 8-level scale. If you have 4 or more of these criteria in a nursing shift, that counts as delirium. If you have 1 to 3, that counts as subsyndromal delirium. And if you look at subsyndromal delirium, you can see that from a patient outcome standpoint, it really sits in between the group who are normal neurologically or psychoneurologically and the group that has full-blown delirium. This is the CAM-ICU, the other scale that may be utilized, where you need both features 1 and 2, an acute change in their mental status and in attention, and then either disorganized thinking or an altered level of consciousness. In ventilated patients, dexmedetomidine may be associated with a lower prevalence of delirium compared to benzodiazepine infusions. Early mobilization should be performed to reduce the incidence and duration of delirium. There is no recommendation, because there's no evidence, for pharmacologic or non-pharmacologic delirium prevention. We do not suggest that haloperidol or atypical antipsychotics be administered to prevent delirium. Let me say that again. No Haldol, no atypical antipsychotics for delirium prevention. There's no data or no recommendation for the use of Dex to prevent delirium. This is one of the situations where there was a disagreement between the groups. So the outcomes group and the delirium group both asked this question and came to different conclusions because they asked the question slightly differently. So it's a little bit confusing. There's no published evidence that treatment with haloperidol reduces delirium, and I'm going to show a study in a minute that may appear to refute that and talk a little bit about that. Atypical antipsychotics may reduce the duration of delirium. We do not suggest using antipsychotics in patients at risk for torsade de pointes. So that would be prolonged QT interval or concomitant medications that may also prolong the QT interval, or patients who have a history of this dysrhythmia. We do not recommend the use of rivastigmine for delirium, and for delirium that is not related to alcohol or benzo withdrawal, we suggest dexmedetomidine rather than benzodiazepines to reduce the duration of delirium. So I'm going to go through now, those are the recommendations. There's a bunch of others that are more statements. And so this is one of the first shots across the bow by Jose Maldonado and his group. It was a cardiac surgery study. Unfortunately, it was an unblinded study. Patients, nurses, and physicians all knew who was getting Dex, who was getting propofol, who was getting midazolam. Nonetheless, they showed a dramatic reduction in the incidence of delirium with dexmedetomidine compared to propofol or midazolam. Because of the unblinded nature of this, however, we assigned this a lower quality of research. This was another kind of shot across the bow that perhaps lorazepam can increase the incidence of delirium. This is from the Vanderbilt group, and you can see that with 10 or 20 milligrams a day of lorazepam, your incidence of delirium approaches 100%. This is the MENDS study where patients were randomized to receive either continuous lorazepam or continuous dexmedetomidine, showing a higher incidence of delirium and coma-free days in the group receiving dexmedetomidine. That's a good thing. A different way to look at their delirium incidence was presented about a year later. The black bars are the Dex group, the grayish bars are the lorazepam group, and you can see that at baseline they were similar at a little above 60%, but quickly within a day of starting Dex versus lorazepam, there was a dramatic difference in the incidence of delirium between the two groups. SEDCOM, with many of the patients enrolled from Australia, randomized patients to either Dex or midazolam infusion for up to 30 days. Similar kind of presentation. At baseline, about 60% incidence of delirium, and very quickly, within a day of starting Dex, the delirium rate dropped compared to midazolam, where it remained high for several days. This was not a randomized study, but was a historically controlled study, and it's very busy, a lot of data, a lot of dots, but I want to just take a second to point out a few things. This is from Joanna Skrobic, who invented the ICDSC and does a lot of delirium research. And what she did is she measured what was going on in her ICU and then implemented a protocol to try to minimize benzodiazepine use, reduce deep coma-like sedation, and provide more targeted analgesia. And what she was able to show is that the pain scores here, the NRS, was lower after implementation, 1.1 versus 1.6, and yet the morphine doses were dramatically lower. How can that be? How can she have lower morphine doses but better pain control? Because she's giving it to the right patients. So those tachycardic patients who aren't having pain, they don't get morphine, they get a beta blocker. The number of patients who required no opioids because they weren't having pain went from about 28% up to about 37%. The lorazepam equivalent doses were more than cut in half, and the number of patients who required no benzos or no propofol went up after implementation of this thing. The incidence of delirium was about the same in both groups. The incidence of subsyndromal, that group that's at risk to develop full-blown delirium, went down by about 8%. And finally, the incidence of iatrogenic coma, length of stay, hospital stay, etc., was much improved. So early mobilization, you know this data well, getting patients doing activity in bed, sitting on the edge of the bed, and even walking while intubated and attached to a ventilator had a dramatic effect to improve outcomes and reduce the incidence of delirium. And this is a different study, but one that also showed the same thing, a reduction in benzo use, a reduction in patients requiring narcotics, and a reduction in coma-level sedation. So whether the mobilization effects on delirium are related to less drug and lighter levels of sedation or to the activity itself, I don't know if we understand that yet. Non-ICU prevention strategies have been shown to be very effective outside the ICU. This is data from Sharon Inouye, who showed about a 40% reduction. And what did those interventions look like? Reorienting the patients, trying to use non-drug sleep protocols by not waking the patients up every night, early mobilization, limiting catheters and restraints, giving them their eyeglasses and hearing aids, trying to fix their laboratory studies, and trying to prevent withdrawal. No ICU data to support this yet. The MENDS trial was a study that looked at randomizing patients to either Haldol, ziprasidone, or placebo. Now, it's not clear whether this was a delirium prevention study or a delirium treatment study. You didn't need to have delirium to get into the study, although about 60% of the patients did at baseline. And what they showed was that it didn't matter which of the three drugs you used, there wasn't any difference. So some people have interpreted this as the antipsychotics don't work, but I'm not sure what they don't work at. Do they not work at treating, or do they not work at preventing? So I'm not sure how to interpret this study. This is the study that was recently published that was not part of our guidelines that may refute the potential benefit of haloperidol. A couple of things about this study that was published earlier this year in Critical Care Medicine. Primarily a very low sick group, Apache 2 scores of 8. That's not too sick. Their time in the ICU was less than a day, and very few of them were intubated. What they found was that the group who got haloperidol intravenously for 12 hours versus a placebo had a statistically shorter ICU length of stay from 21 hours to 23 hours. I don't know that that's a clinically significant difference. They had a slightly lower delirium incidence and slightly higher, statistically at least, incidence of delirium-free days. Look at the mortality at 28 days, 1%, 2%. So this is an incredibly well group of ICU patients. Rarely died, spent less than a day in the ICU. I don't know that that necessarily applies to our more typical critically ill, ventilated, high Apache score group of patients. This is the data that looked at treatment. This is the first randomized controlled trial comparing haloperidol or olanzapine. Again, it was done by the group in Montreal, and they showed that the two worked very similarly, no difference between them. The other study that's out there was a quetiapine versus placebo study with haloperidol rescue in both groups, and what they showed was a dramatically faster elimination of delirium in the quetiapine group compared to placebo with Haldol. And then this study, again from Australia, and I believe we'll hear from Michael later, open label study compared Haldol or Dexmedetomidine for patients that had agitated delirium with a much longer ventilator time and ICU length of stay in the group that got haloperidol. This is the Rivastigmine study. Patients are randomized to placebo or Rivastigmine. This study was stopped early because patients died more often and had a higher incidence of delirium if they got Rivastigmine. Don't use it. This is the SEDCOM data, branching out the patients into those who had delirium at baseline versus those who did not. The group that had delirium at baseline, only 68% of them had delirium during study drug when they were getting Dex, compared to 95% who were getting midazolam. So if you have delirium, it looks like it goes away quicker with Dex. The no delirium at baseline group, which was about 40% of those patients in the SEDCOM study, only about a third, 32%, developed delirium, and the group that got midazolam, it was about 55%. So we can branch out from that study compared to baseline. So to summarize the delirium stuff from the guidelines, there's a no as far as preventive haloperidol or atypical antipsychotics, and no rivastigmine or haloperidol for treatment. Yes, or you may use routine monitoring, early mobilization, atypical antipsychotics, and dexmedetomidine if it's not drug withdrawal. So to summarize the ICU pain, agitation, and delirium guidelines, we should assess pain using the NRS 0 to 10, the BPS, or the CPOT. We should treat pain with opioids, and then there's also other possibilities, non-opioids, regionals, non-pharmacologic, and pre-procedural preventive therapy. For sedation, we should assess sedation level with RASS and SAS. We should target light sedation. That's a RASS of -2 to 0 or a SAS of 3 to 4. We should use protocolized sedative approaches or daily sedation interruption, and then early mobility and linking awakening and spontaneous breathing trials. And then as far as delirium goes, we should assess delirium with either the CAM ICU or the ICDSC. We should treat delirium, although we don't know yet for sure what may be best, perhaps the antipsychotics, perhaps dexmedetomidine, avoiding deliriogenic drugs, and going from there. And I'll stop there. Thank you very much.